Good morning, everyone. It's my great privilege to introduce this morning's keynote speaker, Dr. Zindel Segal. And I wanted to just say a few words about him. I know we're all in for a treat. Zindel is a distinguished professor of psychology in mood disorders at the University of Toronto, Scarborough, and a senior scientist in the Campbell Family Mental Health Research Institute at the Center for Addiction and Mental Health. And most of you in this room probably already know this, but Zindel literally wrote the book on mindfulness-based cognitive therapy for depression, as well as 10 or so more books. And he and his colleagues, Mark Williams and John Teasdale, pioneered the use of mindfulness-based techniques, training programs, interventions for their use in mood disorders. And he has many awards and honors, and he's also quite an accomplished, accomplished publication record. But I think what's really interesting is that he also has a continuous funding record for the last 15 years or so. And I think I'm not alone in saying we are really lucky that the wise choices were made by the federal agencies, both in the United States and Canada, to choose to fund this work, because this work has allowed for the whole field of clinical psychology to benefit. And it's really bolstered the armament available for the use of mindfulness-based cognitive therapy, not only in depression, but really in, broadly speaking, many affective disorders. So please join me in welcoming our morning keynote, and actually somebody who I think is one of the kindest and coolest people I know, and somebody I'm very lucky to call a friend and a colleague, Dr. Zindel Segal.
Thanks, Amishi. That was great. Thank you. Hi, everyone. Good morning. Mishi, it's always nice to be introduced by a friend. There's a palpable warmth to those kinds of introductions, so I appreciate that. I also appreciate Mind and Life inviting me to provide a keynote address, and what I'm going to talk about is the whole question of mindfulness therapeutics, which these days is considered a potential, okay, let's figure out how this works. How do I go back? Yeah, I need to go back. Okay. Can we go back 2 slides? Super. Thanks. Mindfulness therapeutics and the promotion of mental health. Mishi and I were actually just talking backstage before I came on about how mindfulness these days is not seen as a radical proposition in the field of mental health. But 15 or so years ago, it was. And it was risky. And they were calculated risks. They were risks that were taken based on intention and information and data at the time. But these days, the notion of mindfulness therapeutics and the promotion of mental health is something that I think we're working from at the data level, but also at a mechanism level. And I'd like to provide some insight into what some possible mechanisms might be, and also wrap that into the story of how MBCT was developed, because at its starting point, MBCT was a way of searching for mechanisms that could be trained more specifically to help people dealing with a mood disorder. And this work has a wonderful trajectory. That trajectory has been supported by a number of different people. These are some of the folks that have contributed along the way in terms of studies on mindfulness-based cognitive therapy, the efficacy studies, the neuroscience work, the web-based online dissemination of MBCT, issues relating to training integrity and quality assurance, and also the work in our lab with our graduate students to try to take some of this work forward and look into different domains. So 2 studies appeared in 1990 and 1992, about 20 years ago, that really sparked this field. And the findings were that psychological therapeutics were possible in the treatment of depression. And remember, psychological therapeutics at that time represented a contrast to biological therapeutics. Biological therapeutics were fairly easily understood in terms of the effects of antidepressant medication, the effects of neurostimulation therapies, and other biological interventions, but psychological therapeutics suggested that people could internalize certain ways of looking after themselves, dealing with potential mood triggers, and prevent those triggers from cascading into larger episode and symptom-defined cases of depression. And so this study, 1990, kind of kicked things off. There was another study by Irene Elkin and Tracy Shea, came out at around the same time. But what this study showed was in people who were all treated to wellness, different treatments had different outcomes over 3 years. And one of those treatments was, the top 2 lines, imipramine, an antidepressant medication, continued for 3 years, gave people the best chance of surviving without having a new episode of depression. But the 2 other lines that I'm pointing to here on the slide show that once a month interpersonal psychotherapy provided the same level of protection over 3 years that was significantly greater than placebo. It was less than what you can achieve with imipramine, but it was better than what you could achieve with placebo, and it suggested that providing people with some kind of maintenance-based care on a monthly basis could allow people to internalize and bring into play in real time ways of looking after themselves. Another study published in '92 showed that cognitive therapy could do the same thing, but this time the learning was concentrated in the period when the therapy was being delivered. So in this slide, people who had cognitive therapy and were then followed for 2 years were not continuing in therapy, but were still looking after themselves in ways that presumably involved utilizing the skills that they'd learned in therapy, taking them into the world. And their protection was on par with what people who were continuing to take an antidepressant were able to achieve. So it really suggested that there are things that may be taught to patients that allow them to, in a sense, become their own therapists. And we really needed to know what that was, and we also needed to understand that it may help us address a vital paradox in the treatment of depression in the long term. Because in the long term, the picture of dealing with depression and mood disorders is that it is a phasic, episodic disorder with high rates of recurrence. If you're able to do something about the rate of recurrence, you can dig into the potential for this disorder to have a chronic course and shorten its time length. And what's really important is to consider the paradox that maintenance care, these kinds of interventions, are really best suited, paradoxically, at a time when symptoms are relatively quiescent. So you have these 2 things going on at the same time: low symptom burden, but a recommendation for continued treatment. And sometimes that's a tough sell. People feel like they're doing well, they're out of the woods, they don't want to keep coming back to see a therapist, they're feeling okay. Why do they need to go and continue for 3 years in a treatment or a mental health system, or continue to see depression as defining an important segment of their lives? And one of the issues is that they continue to be at risk. And as we saw in the other 2 slides, these interventions reduce their risk and give them a leg up in terms of doing nothing, discontinuing medication, or even in those cases where medication has side effect burdens and is intolerable, and people decide to discontinue on their own. And this is really the starting point of mindfulness-based cognitive therapy. So the IPT group, David Kupfer, Ellen Frank, were also involved with the MacArthur Foundation at the time that had a node devoted to study of mood disorder prevention and treatment, and they gave me a little bit of money to develop a maintenance version of cognitive therapy. So they were sort of saying, we've got this maintenance version of IPT, wouldn't it be nice to have a cousin version of cognitive therapy available? And so they said, could you do this? And it's not a good idea to turn down money when it's offered to you in the context of research, given how hard it is to get funding. And I said, yeah, I could do that. And so what I did was I actually used the money to bring these colleagues of mine together, Mark Williams, John Teasdale, and we sat around a table thinking, how could we design and build this version of cognitive therapy that could be used in the maintenance context when symptoms are low, there's not a lot of negative thinking going on, but people still do need to look after themselves. And so instead of just chopping up CBT so that it could be delivered once a month, maybe with a less ambitious agenda, maybe with a focus on interpersonal events, we actually thought it might be good to select a treatment target, to find a target that carries risk in people's lives, teach people how to fold a different way of relating to it and seeing if that reduced relapse. And at that time, the studies indicated that the best treatment target for preventing, the best psychological treatment target for preventing relapse turned out to be dysphoria-linked cognitive elaboration. And what that means is when people have recovered from depression, small amounts of negative mood for vulnerable individuals, small amounts of negative mood, so a setback, resurgence of sadness, can tip them back into a way of thinking that is reminiscent of the semantic and associative networks that were present in a depressive episode, and all of a sudden that view starts to become more and more dominant and more accessible. Could we find a way of helping people work with that so that these states of sadness could remain mild and not cascade into something more severe? And there is good evidence for this notion of what's now called cognitive reactivity, but is really mood-linked cognitive elaboration as having this risk potential. In one study that we did, we used sad mood provocation. We brought people into our lab. We used some very sad music and autobiographical recall of a sad time in their lives to induce a brief sad mood. And we found that over 18 months, the people who responded to that sad mood, that brief sad mood, by changing their thinking in a direction of increasingly endorsing depressive thought patterns, had the highest rates of relapse compared to people who were relatively unaffected by the sad mood or maybe increased their endorsement of positive thoughts. So the sad mood didn't perturb them as much, but other people fell back into it. And to the degree that they did, over 18 months, they had very poor outcomes. Another piece of evidence is that, this is from a more recent study, if you look at individuals within the general population and you try to predict who will become depressed over 24 months, and of course this is feasible because depression does have a high prevalence rate, you find that people who are experiencing negative life events and who have this cognitive approach of elaborating sad moods into stories and narratives that are reminiscent potentially of depression are the ones over 24 months who have the highest rates of relapse. So we felt that we found a treatment target. And we felt that this was very important in terms of developing a treatment around it so that people could be armed and able to work differently with it. So if this is the poison, what's the antidote? And so there are a number of different ways of thinking about what the antidote is. And I'm going to turn to poetry to try to provide you with an answer. And so this is a poem. It's written by Billy Collins, who used to be the poet laureate of the United States. And it's not about depression, it's about insomnia. He's writing about his insomnia. And what I'm going to ask you to do is to think about, as you listen to the poem, what elements might there be in here of a potential antidote to reacting, to elaborating negatively the state of mind and the state of body that insomnia brings. So the poem is called Insomnia. It's from 2001. Even though the house is deeply silent and the room with no moon is perfectly dark, even though the body is a sack of exhaustion inert on the bed, someone inside me will not get off his tricycle, will not stop tracing the same tight circle on the same green threadbare carpet. It makes no difference whether I lie staring at the ceiling or pace the living room floor. He keeps on making his furious rounds. Little peddler in his frenzy, my own worst enemy, my oldest friend. What is there to do but to close my eyes and watch him circling the night? Schoolboy in an ill-fitting jacket, leaning forward, his cap on backwards, wringing the handlebars, maintaining a certain speed? Does anything exist at this hour in this nest of dark rooms but the spectacle of him and the hope that before dawn I can lift out some curious detail that will carry me off to sleep, the watch that encircles his pale wrist, the expandable band, the tiny hands that keep moving this way and that. Reading poetry is always an iffy proposition because the lines that speak to you may be like, what? What's he talking about? But taking the prerogative of being the keynote speaker, let me suggest a couple of things that to me sound like they might be an important antidote to the capacity of working, greeting, meeting, and potentially befriending insomnia in a way that's different than having a reactivity to it. And so some of these lines stand out to me. So here is a relationship to insomnia. My own worst enemy, my oldest friend. A recognition of familiarity. This has been here. We are both looking at the different facets of this experience. The body is a sack of exhaustion, inert on the bed. The capacity to tolerate this distress of being exhausted, lying inert, nothing much is happening. And then the curiosity, the optimism, potentially the kindness, and the hope that before dawn I can lift out some curious detail. So this poem conveys a sense potentially of a stance that's different than cognitive reactivity, of catastrophizing, of judging, of furiously, frantically problem solving. This is a different way of meeting the experience. And it's been a way of meeting experience that psychotherapy has also referenced from time to time. People have written about this, they've used different terminology, they've described it with different language. But it's been there as a moment of insight, as a moment of understanding. Whether it's Freud, Beck, the Dalai Lama, others who have talked about mindfulness in the context of psychotherapy, self-distancing, decentering, de-identifying from mental contents, cognitive diffusion, the observing ego. But one of the things that I continue to come back to is that this is not enough for people. This moment of insight, of awareness, of wow, I can watch my insomnia, it can be there and it can be gone in a flash. And then what happens when someone insults you at work? What happens when you're dealing with a real setback and you're flooded with these feelings? People need training. They need practice. They need to continually generate and regenerate the capacities that will provide them with a moment of pause and choice and potentially come at their experience from a different perspective. And so when we looked at what are the forms of training that are available, one of the places we landed was, well, cognitive therapy seems to do something. It does seem to utilize these externalized, structured ways of getting people to write down their experience and to notice it. And if you look at a 7-column thought record, which is essentially a very prevalent tool in cognitive therapy, you can see that there are elements of this description, of this externalized and concretization of experience that allows people to build tolerance for distress. People need to describe a situation. They need to look inside and see what emotions are there. They need to rate the emotions. It can also help them recognize automaticity. Oh, this thought just popped into my head. This way of thinking just popped up. And so people can start to see that these things are also there. They're also present. Thoughts can be viewed as mental events. They can be viewed as ideas that can be evaluated from one side or for the other side, evidence for, evidence against. These are all building different relationships to this sometimes mental content that we don't even think twice about completely identifying with. And it can also engender an attitude of curiosity instead of judgment. Not, why am I thinking that way, but, oh, this thought is here. Isn't that interesting? I wonder how I can look at it from different points of view in terms of, has this happened before? Is there evidence that's supportive? Is there a context for why I'm thinking this way? But cognitive therapy and the thought records are used in acute depression. They're used when people are depressed, when people have high symptom burdens. And remember, what we're trying to do is to provide people with a form of training, a form of developing these skills when symptoms are not exceedingly present. The symptom burden is low. People are searching for wellness. They're not defining themselves necessarily by symptom burden. They're also not dealing with a lot of negative content. these thoughts are quiescent. They're not dominating consciousness. There may be other things that are going on. And so the idea that someone could pull out a thought record and start to fill it out seemed a little bit of a far-fetched notion, because the content that thought records are designed for isn't going to be present every day. And so then we fast forward back into this timeline, and John and Mark were at Cambridge at the time, and Marsha Linehan was doing a sabbatical in Cambridge at the time. And she was sort of becoming a little bit curious, maybe competitive, maybe envious, I'm not sure. What are you guys doing going back to Toronto, back and forth, and then I would come to Cambridge sometimes. What are you talking about? And so they would talk about, our ideas around how to provide this training for relapse prophylaxis and this capacity for decentering or developing a metacognitive approach or a different relationship to negative experiences. And she said, well, you should check out the work of Jon Kabat-Zinn, because he's sort of been doing this with chronic pain. And he is providing people with this direct form of training in the metacognitive stances that you feel are going to be helpful. And so I remember we were sitting around the table, and none of us were really interested or dedicated to meditation or to contemplative practice. Now, interestingly though, in our younger days, I did flirt with TM for a little while. Mark Williams had pastoral training as an Anglican priest, which involved prayer, and it turned him off, and he stepped away from that. John Teasdale, I remember once going to Cambridge with him, and we went to a Quaker meeting on Sunday morning, and he was reading about Krishnamurti. So we were familiar with it, but it wasn't our frame of reference. And we actually, when Marsha made the suggestion, we all went to the local bookstore and we bought a copy of Full Catastrophe Living, like just to see, well, what's this all about? And we were reading through Full Catastrophe Living, and we came to these passages where John, it's a wonderful example of an assimilative schema at work. We kind of left the passages where he's talking about mindfulness and opening and all of that to the side, but we came to the passages where he describes people working with thoughts and seeing how they don't have to respond to their thoughts. There's this example of a guy who was washing his car at midnight because he had to get his to-do list done, and he could see, oh, I've got all these thoughts. And so we were talking to each other, and we said, Jon Kabat-Zinn is a cognitive therapist, he just doesn't know it. But it opened a door where we felt that there was a potential bridging between what he was doing, what we were looking for, and we visited him, sat in on classes that he and a lot of the senior teachers at the Center for Mindfulness were conducting. And it was incredibly helpful, generous, illuminating, and it allowed us to develop the first version of MBCT, which we called attentional control training. We didn't use the word mindfulness because we thought it would be too much of a risk, a kind of career suicide move. And we got funded by NIMH for an R21 to just do some treatment development to develop this. And I've actually pulled these sheets of paper from the initial 1995 MBCT treatment manual. And what you can see is that there is this focus on thoughts and feelings, but it's very cognitive and it's very attentional oriented in the sense that we were interested in helping people see the relationship between thoughts and feelings, which is something that happens in CBT, but we weren't interested in working at the content level, which is something that does happen with thought records. So thoughts and feelings, yes. Content, no. How do you help people move away from content? You use attention to help them find an alternative focus. And so the value in our view at that point of attending to the breath was a way of removing processing resources from negative thoughts and feelings, thereby kind of choking the oxygen that these downward spirals needed, and presumably, in time, they wouldn't have that same powerful linkage. And we merrily ran some pilot groups. I remember running my pilot groups and giving people a cassette recording of mindfulness practice that they needed to do. I wasn't doing it. I didn't think I needed to do it. I saw it as a kind of relaxation training that would help them train attention, hence attentional control training. And so that was like a huge reality check for me, because the pilot groups went well enough, but there were moments when people were asking directly. They were talking about homework, or they were describing things in the group started to tear, started to get somewhat emotional, and they asked me what might I suggest around working and meeting these emotions from the mindfulness perspective, and I really didn't have very much to tell them. I would fall back on my cognitive therapy skills. And so slowly, all three of us committed to our own personal mindfulness practice. I think the important point here is that it took me about 2 or 3 years, well, maybe 2 years, before I did it. And I remember it was a cassette series from Sounds True that Sharon Schlalsberg and Joseph Goldstein had recorded, with a little bit of a Dharma talk on one side of the track, and then practice on the other side, and then moving from that into more regular practice. And with that, the pilot groups and our understanding of what went on, we were able to utilize this idea that we're not really training attention as much as helping people develop a different relationship to experience. And what that relationship to experience looked like had a lot to do with meeting aversion, with bringing a kindly curiosity, and with the very intensive, intentional attention training that a lot of the practices in our program provided. And so with that in hand, we then ran the first RCT of MBCT, found that there was this separation in relapse rates between people in our program and people who had treatment as usual, who all of whom had recovered from depression, and published our first book. And at the time when we published our book, we were very clear in saying, if you want to deliver something and call it MBCT, you need to have your own mindfulness practice, which to the psychotherapy community was a burdensome message, to say the least. But it was the right message. And so we've written materials to support instructors, to support patients, and we've been very declarative in terms of making handouts for sessions available, audio recordings for all the practices, in an effort to be generative so that more people could have access to this work. And the scope of MBCT has moved into different domains, leaving the initial point of mood disorders to see whether it's helpful in other problems related, such as generalized anxiety disorder, health anxiety, chronic fatigue, mood symptoms in cancer, and quality of life. And some of these data have been very encouraging. And the efficacy data for MBCT is also very strong. This is a study that was published in The Lancet last year, the largest randomized trial of MBCT so far. About 420 patients, I believe. 2-year follow-up. Everyone starts in recovery from depression. Everyone is treated to recovery with an antidepressant. And so one group, the group in the blue line, is just continued on their antidepressant for 2 years. This is still the standard of care. Another group is provided with MBCT right at the start with tapering support. In other words, support for coming off their antidepressant over time. And what you see is that there's no difference in the level of protection afforded to people who continue to stay on an antidepressant and those who come off and who are still practicing the skills taught in the MBCT program. Although that's an assumption I'm making. They participated in the MBCT program, they attended a majority of sessions in the MBCT program, but the relationship to practice is something that we still, I think, in our hearts would like to see nice and robust, but the truth is it doesn't always show up that way in studies. But we can see that this is a significant survival effect when the two treatments are compared to each other. In a study that we did, the same benefits of equal protection for people who had MBCT or continued on an antidepressant, the people who had whatever was helping them stay well taken away and being put onto a placebo, they're the ones who do worse. So some form of protection is needed. If you take it away and people are doing well, but they're kind of left adrift, then they do very poorly. MBCT and an antidepressant seem to offer equal protection, which is very important. And then in a individual patient-based meta-analysis conducted on about 1,500 patients published this year, what you see is that over all those studies, there's about a 31% reduction in risk of relapse in people who had MBCT, whether that's against comparison groups that are usual care, or antidepressant based. So it's fairly robust, and on the basis of this evidence, it's now being rolled out in the UK as part of their increased access to psychological treatments, and it's been recommended by NICE, the National Institute for Clinical Excellence, as one of the treatments that the National Health Service in the UK is authorized to fund and authorized to make available on a wide-scale basis, and that's a real public health initiative. I think these data have been very persuasive. Additionally, MBCT, this is getting back to the mechanism story, reduces cognitive reactivity. And so, as you can see here, people that have had antidepressant medication at low, medium, and high levels of cognitive reactivity tend to show an increase in depressive symptoms as the level of cognitive reactivity increases. MBCT keeps people relatively flat at these different levels, so there's almost a dissociation between these two factors. We've also done some work, and Norman Farb gets a lot of credit for this, in looking at the neural bases of mindfulness interventions in a clinical context. And what we found, and I'm going to just describe this in very broad brushstrokes because I want to get to some new data that we've recently generated, is a way of understanding when sadness is present. And so these are people who are in a scanner, they're watching sad movies, and they're watching neutral movies, and when they feel sad, we can see what kind of brain regions are sort of activated while the experience of sadness is present. So what you find is a very high level of activation in midline prefrontal regions, and when you compare the effects of the same sadness exposure in people who have been trained in mindfulness, there's a reduction in that preponderance of midline prefrontal regional activation. At the same time, while the midline prefrontal areas are active, there is an inhibition on viscerosomatic lateralized areas that provide information about interoceptive awareness, almost present moment experience. And training in mindfulness restores some of that. So that if you can think about it, perhaps people who are untrained and feeling sad in the scanner are drawing primarily on one source of information, which is more of an executive network, analysis, evaluation, self-reference. What do I do with this? What does it mean to me? And getting far less input from parts of the brain that are active when information about body state, present moment awareness are available. Training in mindfulness reduces the discrepancy between, or the imbalance maybe, between these two different channels and provides people potentially with two channels of information to draw from. There still is some of the executive network activity, but there is also a little bit more of an input from current body state, sensations, body awareness. And these differences, this rebalancing seems to make a difference. If you look at the extent to which the insula is restored to baseline when people are feeling sad and they've had training in mindfulness, there's a negative correlation with depression measured on a one-time basis. But very interesting preliminary data from a study I'm going to discuss also suggests that the extent to which present moment awareness is restored in the face of sadness can be predictive of outcomes over 2 years in terms of relapse risk. This is one of the first findings of this predictive capacity related to neural changes that are a feature of mindfulness practice. Now, I do want to warn you, this is preliminary data. Norman and I were sending analyses back and forth as late as Monday, so things could change. But I wouldn't be presenting them if I thought they were really flaky. I think there is something here, and we're going to try to flesh them out. And these data come from an interesting study that we conducted where we were really trying to look now at the other side of the coin. We understood the risk related to cognitive reactivity. We understood that people need to be trained and have regimens of response that allow them to build a different relationship to these risk factors. And so in this study, we were wanting to see, well, what is that? What does that look like? And how predictive is it? And does it provide some measure of wellness? And does it lead to changes in the brain? And how do we understand this from an integrative perspective, where we can talk about practice, we can talk about metacognitive capacities, and we can potentially talk about neural changes? And maybe there are no bridges to be built between all three of those different domains, but in a sense, that's exactly what Mind and Life is all about. It's about fostering these conversations between different domains, identified and committed to a common agenda of understanding these practices at multi-levels of resolution and analysis, and providing a more fulsome picture of how they can both be incorporated into people's lives and how they can be potentially disseminated more effectively and efficiently. So this study took remitted depressed patients and allocated them either to mindfulness-based cognitive therapy or cognitive therapy with a well-being focus. So this is not a randomized controlled trial comparing one or the other. We're not looking to, and it's not powered to, see, well, does CBT provide more prophylactic benefit versus MBCT? It's getting people well through these two different routes. And I would argue that, yes, there is some overlap. There's some CBT and MBCT, but they are essentially different routes when you see what goes on in these classes. The MBCT classes have as a definitional point 40 minutes of mindfulness practice each class, different kinds of practices, body scans, sitting meditation, essentially the same menu as MBSR, but we've added 3-minute breathing spaces and also a huge emphasis on informal practice in the real world. CBT, each of the sessions is devoted to cognitive therapy principles related to goal setting, activity scheduling, thought records, reducing anxiety, assertiveness. So there's a kind of proactive planning about what people can do. So they are different ways of getting people well, but remember the first couple of slides, CBT shows a pathway to wellness, as does MBCT. Are there mechanisms that are in common that allow us to understand how do people get better? How do people turn on that switch or become agents of their own change? Or are there different pathways? Maybe the mindfulness training pathway provides one approach, maybe the CBT pathway provides a different approach. So what you can see here is that the rates of relapse in both groups were essentially identical, and 34-36 is pretty much on target with what the early MBCT studies were achieving, a 34% rate of relapse compared to a 66% relapse rate in treatment as usual. So I think we can say they were both prophylactic. This is a recurrent group. The mean number of past episodes is around 4. And attendance was pretty good. Around 6, almost 7 sessions out of 8 were attended, which actually I would say is high. Past histories of depression, previous hospitalization. So this is not a normal population selected sample. This is the typical kind of sample who would be placed on an antidepressant as maintenance treatment or might continue to come for therapy just to help them stay well. So the first thing that we notice is that we have a lot of self-report measures. And guess what? We're not going to look at each single one and see how they differ between the groups. So instead, what we've done is we've collapsed and compressed all of these measures by using factor analysis. And what emerges is a single factor, which I've called, Norman and I went back and forth about this, but let's call it decentering. Let's call it metacognitive awareness. And you can see here that the questionnaires that load the highest on this factor are the Wider Experiences questionnaire, which is almost like a metacognitive awareness measure, has the highest loading, 0.83, the FFMQ, 0.78, observe, the FFMQ non-react, 0.7, the Body Awareness questionnaire, 0.62, the attention questionnaire in the trait mood scale, the Peter Salovey scale, 0.7. So we feel like there's some justification in looking at this latent score as a decentering measure. And now we can see how does this change over 2 years. And also you can see that there are a couple of symptom scales there that are correlating negatively, so that's also reassuring. So the first thing we notice is that decentering, well-being, the capacity to develop this metacognitive framework continues to change over 2 years. That whatever gains you achieve in treatment over 8 weeks, they can continue to be propelled on an upward trajectory over 2 years. Maybe that's related to relapse, maybe not, hard to know until you do the analyses. And it is related to relapse. If you do a median split on the extent to which people are able to generate this metacognitive awareness, if you're able to follow the suggestions provided in Billy Collins' poem on insomnia and have that kind of relationship to negative mental contents, or potentially even all mental contents, really, you have a much lower risk of relapse than people who are lower on decentering, who are much more identified, who are much more easily triggered into narrative and unable to really find another way to work with this. How do you develop decentering? It's practice over 2 years. But it's not only practicing mindfulness, it's also practicing CBT skills. Home practice, looking after yourself in one of these two ways over 2 years, seems to be significantly associated with building up this antidote, this stance on experience that allows you to work more effectively with these mental contents. And this is really interesting, and it was a surprise, because honestly, when we did the study, I was thinking that the cognitive therapy skills might fall away and not be as useful, because potentially, yes, there is a practice, and yes, people can do them, but the level of resolution isn't really there as much as it is in the actual practice of mindfulness, where you're working with the thought, you're working with a feeling, you're working with a body sensation that might be difficult, and you're finding a way of holding it in a wider space. You're actually doing the nuts and bolts work, whereas in CBT, you might be doing a thought record, or you might just wake up and say, I need to engage in activity scheduling. And that's what I'm going to do today at 5 o'clock. So there's that lag between waking up and 5 o'clock later in the day. And as I said, please note the red font, preliminary data. It might be that we find some trails in which this message may be qualified or moderated, but in general, people are developing this decentered metacognitive awareness stance through practice. Now maybe, the other thing I thought is maybe this decentering is actually a proxy for a more fundamental shift or more fundamental transformation in people's minds when they see themselves as agents of their own change. And then the practice becomes something that they commit to. So at some prior level, they're seeing this as, these are the things that I need to do, I'm at risk, and I'm going to commit to a menu of ways of looking after myself. And as they look after themselves, decentering increases, but it points to another proxy. We don't know that, and it would be interesting to speculate about it, but at this point, there is this relationship between the way of developing comes through practice, and it's not practice over 8 weeks and then forget about it. These are practice decentering relationships over 2 years. And remember, decentering is one of the protective factors. And you see it here. If you do a straightforward correlation, and this is what I talked about earlier in terms of what is it about these programs? Do people show up and learn something in 8 weeks, and then does practice carry the day? It seems that the relationship between practice and relapse is not straightforward. Neither is it strong, neither is it predictive. But the relationship between practice and decentering is positive and relatively robust, and the relationship between decentering and relapse is negative. So to the extent that decentering can protect, practice helps build decentering. Now, what it also suggests is that maybe the kinds of practices that are involved and offered in these programs need to be fine-tuned or customized in some way so that decentering is seen as an important teaching point. There are so many mindfulness programs these days, compassion programs, all kinds of programs that sometimes I think are not targeted. And it may be controversial to say this, but there's so much out there when I run into people who talk about mindfulness where they misunderstand. They're searching for something maybe more relaxation-based, maybe more, they're searching for stuff that is not necessarily in the domain of decentering, and that's totally fine to have a variety. But I think in the context of this sort of intervention or this sort of work being offered with this population, a vulnerable population, I don't think we want to be offering a whole panoply of different practices. I think we want to look at whether our practices and our teachers are teaching to this capacity that will help people do this for themselves. Sermon over. I just want to talk about a couple more things that are happening in the MBCT world. There is a public health need with respect to MBCT. I think the UK is ahead of the curve in terms of being able to develop mechanisms for wide-scale dissemination for people in recovery, to look after themselves, to maintain wellness, and to build these capacities themselves. What we've done is we've received 2 grants, one of them to develop an online version of MBCT, something that can allow people wherever they find themselves to participate in the same way as people who might be attending an in-person group. Now, it's of course not the same way, but the question from a public health perspective is, if you can reach many, many, many more people, and those people may only get 50% of the saturation that someone coming to an in-person group would get, is that a trade-off worth making? And if you look at public health models, they would answer that question with a resounding yes. The notion of fluoride in our drinking water is an example of putting in just a small amount of something medicinal and expanding it over a much wider scale. So our thinking was, if we could develop an online version of MBCT, provide it to people, let's see how much of it is able to achieve the same goals, and let's see how much of it falls short, especially when it comes to training in mindfulness, where not just the relationship, the dyadic relationship between a teacher and a group, or a teacher and a student is altered, but other elements of the group experience are altered as well. So we're currently conducting a very large trial at Kaiser Permanente in Colorado, an HMO, where people in their depression care pathway are receiving our program called Mindful Mood Balance and evaluating it against what people are ordinarily getting in terms of their depression care. Initial pilot work, this is based on a pilot study of 100 people that we conducted using Mindful Mood Balance, shows that adding this to the regimen of what Kaiser offers to its members reduces residual depressive symptoms. So we're not making people worse, and there is some gain in terms of residual depressive symptoms from people using this online treatment. The engagement is adequate to good. People are attending or logging on, if you will, to a mean of about 5.5 to 6 sessions out of 8. And we're retaining 50% of people who complete 4 sessions and 36% of people who complete all 8 sessions. And if you know anything about online interventions or web-based treatments, those are pretty good numbers, because for a lot of web-based interventions, the numbers radically drop off after 1 or 2 or 3 screen views. So we're able to keep people engaged. There is some benefit. The larger trial will tell us whether there is a case to be made for disseminating this somewhat more broadly. And I just thought I'd give you a screenshot of showing you how we've conceptualized taking the elements of the in-person class and trying to provide it to people who are coming at this work from a remote location. We have people start with a practice. So say the body scan. So the body scan is guided, they're listening, they're prepared, they're lying down. The next screen will provide them, once the body scan is over, with some text fields for them to reflect on their experience and to write down in those text fields what they noticed. They're prompted with questions. And then the third screen is going to provide them with this, which is basically a group that Sona Demidzian and I, my collaborator, conducted, where we are debriefing or inquiring into or listening to their experiences with the body scan, and people can click on video clips that illustrate commonly asked questions, like, how can I apply this skill to my life in staying well? How is attending to my body helpful in everyday life? So the learning engine at the core of this online intervention is that people cycle through it through 3 different epistemological filters. The first is direct practice and experience. The second is a conceptual understanding. And the third is this vicarious viewing of the practice itself. that was our effort to try to saturate the online program with as much of the group experience as we could. And we're going to see where that goes. And then in the time remaining, I want to talk just briefly about some developments in the larger MBCT world as it relates to initiatives to help standardize and assure quality across this modality. There are a number of different training centers that have recently started to offer training in MBCT, and there's variation among them. Some training centers insist on silent retreats. Some training centers are willing to take people with a sort of questionable adherence to this issue of personal mindfulness practice. Many therapists feel that they are already mindful, or they are already able to pay attention in that particular way which connotes a certain type of metacognitive awareness. And there's no dispute about that, and people can certainly appraise where they are on that pathway for themselves. But we feel that there is an important statement that needs to be made, and we've authored this MBCT instructor training pathway so that it can be out there. If you want to do MBCT, this is the type of training that's needed. It's a blend of both the therapy and the mindfulness training that's required. And then finally, we're moving to develop a register for therapists so that people can find an MBCT therapist where they are who has, in a sense, followed this training pathway. Now, it might take 5 or 6 years before this registry is fully representative, but as we start to find our legs and start to come into some measure of harmonization with what is currently available for training in these models and what's considered to be high-level, competent, and adherent level training, I think that the public and people wanting to come into the field will be able to follow it in a way that is much more messaged appropriately and messaged singly. And I think that that'll be of immense help. So I'm just going to conclude here with a couple of points about how I wanted to see this talk move and why I presented what I did. And the first conclusion has to do with cognitive reactivity being very important as a target for prevention efforts, that meta-awareness and decentering, however you define it, seems to be a vital antidote, and they do protect against relapse. That decentering can be acquired and supported through the continued practice of skills, either through mindfulness-based cognitive therapy or cognitive therapy, and that decentering and meta-awareness may be proxies for other processes that we haven't fully understood. But in time, it's possible that this antidote, this approach, is something that we could ourselves understand more fully, customize our efforts, and in the end, take better care of larger numbers of people. Thank you very much. Thank you.